Next is diverticulitis V12. A 55-year-old patient present with the left iliac fossa pain, fever, and fullness in the left iliac fossa. How would you manage him? The differential diagnosis here is diverticulitis or perforated local tumor, locally perforated carcinoma. So first, I would assist it with IV fluids, analgesia, antibiotics, septic, and I will involve the SHDU. Take a history, ask any previous bleeding from the back passage, bleeding per rectal, change in bowel habits, weight loss, abdominal pain, family history, smoking, previous colonoscopy, examination, left fossa peritonism, bloods, full blood count, UNEs, LFTs, CRP, amylase, and chest X-ray to see in the diaphragm. So confirm the diagnosis with CT with the oral and IV contrast. How is diverticulitis classified? So it's Hinge classification: Hinge 1, pericolic inflammation or abscess; Hinge 2, pelvic abscess; Hinge 3, purulent peritonitis; and Hinge 4, generalized circulant peritonitis. With the routine use of CT in the assessment of diverticulitis, there have been several modifications to the Hinge classification published. This patient has grade 2 disease. How will you treat him? So he needs conservative treatment by a gut test. So you can only have clear fluids, antibiotics as per microbiology. If the abscess is less than 4, it will settle with antibiotic. If it's more than 4, then I will arrange a percutaneous CT guided drainage. Laparoscopic washout is an alternative depending on my experience and the subspecialty. How would you follow this patient up post-op discharge? So he needs colonoscopy, luminal assessment in form of colonoscopy within 6 weeks of presentation. How would your management plan change for grade 3 and grade 4 disease? Initially, I would arrange for nail by mouth IV antibiotics. The next stage depends on the surgeon who is operating. So patient safety is the key importance, and intraoperative decision makes the key. The ideal operation is a one-stage procedure: resection, intraoperative lavage of the colon, and primary anastomosis in a selected patients. It avoids mortality associated with the stoma and its reconstruction. It is contraindicated in fecal peritonitis, septic shock, unstable patient, chronic steroid disease, and higher ASA grade. Protective ileostomy sometimes can be given, but it is not going to improve the leak rate. Diverticulitis in young patient has aggressive and fulminant course, so it should be treated as early. Hartmann procedure is the standard technique. However, about 50% patients don't come for reversal of the Hartmann. Laparoscopic lavage is also a safe option, but it depends on certain cohort of the patient. How would you manage? How would your management change if the patient was 75 smoker and AF with grade 3 disease? In an unstable patient, I would do the simplest operation: Hartmann procedure, pelvic lavage, and placement of the pelvic drains and come out.